Hi, this is Janine Young. I'm a pediatrician, and I'm going to present on the health risks of unaccompanied immigrant children in federal custody in U.S. communities. And this is a video abstract for the American Journal of Public Health. So my outline is what we'll do is we're going to be talking about unaccompanied immigrant children, definition and demographics. I will also review movement of these children through federal agencies, highlight medical care and gaps in care while in custody and post-release, and also provide some advocacy recommendations that are also outlined in more detail in the paper in American Journal of Public Health. This is a screenshot of the article and a link to the article, which is open access. Let's start and jump in. So who are unaccompanied immigrant children? How many have come? I'm going to give you some demographic data and also discuss why they're coming to the United States. So unaccompanied immigrant children, by definition, are under 18 years of age. Since 2012, and I really want you to think about this, over 600,000 unaccompanied children have arrived in the United States, 600,000. In fiscal year 2023, which is the most recent data that is available, over 100,000 unaccompanied children were released to the United States to sponsors. And as of July 8th, so several days ago, Office of Refugee Resettlement, which is one of the federal agencies that has custody of these children, had close to 7,000 children in their care in close to 300 shelters in 29 states. This is unprecedented, frankly, for our time. This is a website through Migration Policy Institute that we cite in the article and actually gives up-to-date data on unaccompanied immigrant children released to sponsors in the United States. On the right-hand side are top counties where children have been released, including Texas, and California, and Florida. But what I would encourage people, listeners, to do is actually access this website and look to see in your county how many unaccompanied children have been released and the type of advocacy that you could start doing in your communities to address this significant issue with what I would argue is the most high-risk population currently living in the United States. Clearly, this is a lot of data. I applaud Office of Refugee Resettlement for providing this data open access. So there's a link in the top, and this we include in our article, but it goes through the ages and country of origin of where unaccompanied children are coming from. So if you look in the top where the circle is, the vast majority of unaccompanied immigrant children have been teenagers, and this has been back through fiscal year 2012, when really this crisis started, and we started hearing more and more about this as of fiscal year 2014, when I became much more actively involved in this. But I will highlight something else, which is young children, infants through age 12. There's been a shift with more of these young children coming in as unaccompanied. And in general, this is alarming. These are all high-risk children by definition because they are alone. And where are they coming from? So the vast majority have been coming from the Northern Triangle countries of Guatemala, Honduras, and El Salvador, with Guatemala reaching the highest number. But the other thing I wanted to highlight is that this shift over time for all other countries, 13% for this past fiscal year coming from countries all over the world. Gender-wise, it's been majority male, but I will highlight in fiscal year 2023, there's been a shift of more females arriving as well. And then how long are these children in federal care? And I'll go through the alphabet soup of federal agencies that are involved, but Office of Refugee Resettlement has the longest custody of these children. And there's been a shift over time from 2015 to present and pressure to get them out of federal custody and into communities. And so you'll see 2018, kids were in custody for 2 months by themselves in these settings, and a shift to shorter amounts of time, which is, I think, a double-edged sword, frankly, and I'll share some information about this. So why do unaccompanied immigrant children come? Why do immigrants come in general? And I'm sure you've heard of the push-pull factors. There's the push out of countries that I can, and I think all of us in the United States who are US born can only imagine, fortunately, is the push because of abject poverty, war, gang violence that is not over being addressed by the governments, systematic discrimination, abuse, neglect, natural disasters, climate change, et cetera, which is not going away, versus the pull of home, family, culture, language, and the uncalculus that children and frankly all immigrants are making to make these very, very dangerous journeys getting to, I have families from Haiti who are saving all their life savings to fly to Brazil or Chile, living there, and then walking up to the southern US border to try to gain asylum. These are incredibly dangerous journeys. And the question is how do these unaccompanied children get here? And this also gets back to the definition of what is an unaccompanied immigrant child. So sort of obvious is they can come alone. These kids are very, very high risk for sexual assault, abuse, and trauma. Others are traveling with other minors. But I want to highlight two things. One is that some of these kids come with non-relative adults, and they're at high risk of having been trafficked, labor trafficking, sex trafficking, and ongoing trafficking in the United States. And there's a federal law called the Trafficking Victims Protection Act, and I have a link here to it, that requires vetting, separation of these children from non-relative adults to assure that they're not being trafficked. But there has been an overzealous application of this law. And it is this law that is deeming children who are accompanied by non-legal guardian relatives. So it can be grandma, an adult sibling, an adult cousin, adult aunt or uncle who has raised this child, accompanied them to the border. But because they're not a legal guardian relative, the overzealous application of TVPA then thus separates child from grandma, and the child becomes unaccompanied. And this needs to change, and there needs to be new legislation to make this not happen. So what are the federal agencies who have custody of these children? And there are two, and I think the more agencies involved, the more difficult this gets. There's the U.S. Department of Homeland Security, DHS, which is CBP, Customs and Border Protection, that has no background in medical evaluation, medical care of children. And then there's U.S. HHS and Office of Refugee Resettlement, which I've already mentioned. This is a very busy slide, but I want to highlight a couple of things here. And this is highlighting the movement of unaccompanied children from the U.S. border to federal agencies and the healthcare access or lack of access that they have. So if you look at the far left and the arrows, there's X time at the border. And the X time is the question. So children show up at the border, they climb 30-foot walls that we have, they fall, they fracture legs, they have head trauma, they are dehydrated from weeks and months of crossing the Darien Gap and exposure. And they get to the US side, and there's no one monitoring, there are no medical providers there at the US border to triage these kids. So days, you fill in the blanks. A Customs and Border Protection officer who has no medical training then encounters these children at the border, and there's no medical support or backup. That is a gap, and they take these children into custody. There is X time from that custody to transfer to an immigration detention center that's run by CBP. Again, hours, a full day where there's no triage, and there's been deaths reported along at all these steps. And so there's argument to get medically trained people out at the border, which means funding. They're brought to the immigration detention center. You've seen pictures of this. They're kids in cages where there's EMT, emergency medical technician, who will triage. But again, there are easy misses. There are no MD medical doctors there to evaluate these kids. And within 24 hours, there are mid-level providers, physician's assistants, or nurse practitioners who evaluate all unaccompanied immigrant children. But again, gaps, dehydration, respiratory distress that is being missed. And there are no vaccines provided. 72 hours in CBP detention with the Flores Agreement, which is a federal agreement that requires children, unaccompanied children, to be transferred to ORR custody. And you can see this dance and movement, which is, loss of information, loss of care, frankly, for these kids. They're transferred to ORR custody at any of the close to 300 sites across the country, where again, a mid-level provider needs to evaluate them within 2 business days. So again, gaps. I will say that they're vaccinated, and a very good job done with this. They have TB screening, and I'll go through some other screening that is done. As I shared in another slide, they're in their custody there for 3 weeks, approximately. And then they're released to a U.S. sponsor. High-risk children, I find it ironic that there's only a subset of unaccompanied immigrant children who are deemed high risk, and there's no definition that we've been able to access to allow us to determine who would be high risk of unaccompanied children. But those high-risk children are assigned a social worker for 4 months, and that's it. And then there's no federal oversight of these over 600,000 children that are in the United States currently. They're released to most states who don't have health insurance for undocumented immigrants, except for DC, and 11 states with coverage, and none of these kids have legal status. And then there's a gap of 2 to 3 years with the delays to appear before an immigration judge to argue their case. And that is it. And so I cannot underscore the issues with the loss to follow-up of 600,000 children who are at incredibly high risk and no oversight of what happens to them after this time. I'm not going to spend a lot of time on this, but this is examples of acute medical issues at the border that have been seen in prior chronic diseases that are most often unknown or known, where CBP officers who have no training and are not able to identify children who are severely dehydrated, have measles, varicella has been documented, et cetera. And then the chronic issues, so you have acute on chronic issues that are undiagnosed. And so again, there have been deaths documented throughout this time since 2014. This is another busy slide, and I apologize for it, but this is the current Office of Refugee Resettlement medical screening form for all children who come into their custody for several weeks. It has been updated over time, and this is most recently released. And the update has been because of advocacy that has happened on the part of pediatric providers, people on public health. So I cannot understate the need for advocacy to affect change at all levels, both at state and federal level. However, I appreciate the updates, but they're still missing things, and I'll highlight some of these. CDC Division of Global Migration and the CDC Domestic Refugee Screening Guidelines provide comprehensive evaluations for all new refugee arrivals. This screening does not mirror that, and the risk factors are the same for both populations. And in fact, these kids come from the same countries that refugees who have legal status here have. So what I'll highlight is, all children should be having a complete blood count with differential. Anemia is very common, eosinophilia and parasitic infections. This is how you diagnose them and treat them. So this is being missed. Lead screening is recommended for refugees and any infant through age 16, plus pregnant or lactating females. So this is being missed. HIV, I welcome the change that they are now screening all children. This is an update. But what is still being missed is vertically transmitted hepatitis B, hepatitis C, and syphilis. And I will highlight a couple things as well, which is these kids are having these evaluations done within 2 days of arrival in custody. And they're being asked if they've ever had sex, had sexual abuse, or sexually assaulted. And in expert opinion, most traumatized children are not going to share this information. And so they are missing these infections. And then these children are being released into communities where none of this testing happens. TB testing is done very, very well. I'm not going to spend time on this, but everyone is getting tested for TB. And this is the mental health screen that is done. In the ORR sites, there's no child psychiatry on site. Again, these questions are asked within 2 days of arrival. And, kids, if you're not trusting, if you've been trafficked or you are fearful, you may not answer any of these questions. So again, high risk post-release. So, we talked about release to sponsors, and this is again data from ORR, and I applaud ORR for allowing this to have open access. And this is from 2021 and 2022, the most recent data. In 2021 and 2022, over 200,000 children were released to sponsors in the United States. The majority were released to immediate family members, over 100,000, close to 200,000. But what I'll highlight here is even those family members might not know these children. Many families come to the US, send money back to their other family, their children, and the children might not remember their parent or their, sibling who's an adult. So this is very traumatic. But I want to highlight close to 12% are released to distant relatives, and this is just for 2 years. And then 14% were released to non-family sponsors. And this is a huge issue. And I'll tell you why in a second. But what happens is there's been a push for Office of Refugee Resettlement to do more home studies before release to any of these settings, and also to provide more post-release services with social workers. But again, I want to highlight a couple things. One is the post-release services with a social worker is only for 4 months. And the home studies are happening in a minority of cases. So in 2022, 14% of kids had home studies before they were released to sponsors or guardians, and 43% had post-release services. In 2021, 5% had home studies and 20% post-release services. The change over time has come because I would actually argue that Hannah Dreier, who is an investigative reporter for the New York Times, did an entire series starting in February of 2023, looking at risk factors for unaccompanied children released in the United States. And what she found was that many of these kids were not in school and were being labor trafficked. And there's an entire series that is cited in our paper, and also you can find this online. Because of her work, there was huge backlash and federal investigations that started requiring an increase in home studies and other ways to assure that these children aren't being trafficked. And these are some of the changes that were made. But again, I want to highlight that kids are getting the maximum is 4 months of social work involvement. And I'm not going to go through this whole list. So there are clearly still needs for advocacy and funding. And I would argue that people who are listening to this video abstract could do so in their areas. And these are some of the areas of advocacy. And we have a long list actually in our paper, which is, medical screening needs to mirror what CDC domestic refugee screening guidelines recommend. And I'll provide a link to those at the end of this. We really need a national electronic health record similar to what's used for refugees so that we can access their records, because once they're released from ORR, we don't have access to anything and we're left to do these tests again or expand them. There needs to be an expansion of unaccompanied refugee minor program. These are refugees. It's a very small program that has very well funded that puts children in foster care and allows for significant oversight to assure that they're in school ongoing. Social workers need to be funded to follow all released children who are all at high risk for at least a year. There needs to be an increase in the number of immigration lawyers and also a prioritization and fast tracking of unaccompanied children cases so they get legal status. And what we've seen nationally is that there is no systematic training of federally qualified health center providers, hospital providers, ER, urgent care to even identify children who are formerly unaccompanied. So they're hidden in plain sight really everywhere. And then finally, there needs to be legislation passed that addresses the overzealous use of the Trafficking Victims Protection Act to separate accompanied children from grandparents, grandmothers, and grandpas. So in conclusion, unaccompanied children will continue to arrive at the US border seeking legal protections. This is an issue that's not going to go away. These children have some of the highest risks for untreated medical and mental health issues, trafficking in the US, abuse, neglect, ongoing. There's much room for advocacy to improve the care of these children from arrival, crossing, federal custody, and post-release. And for more information, please read the full paper on the AJPH website. And here are some resources that I mentioned throughout this talk, and please feel free to access those. And thank you so much for listening.